Hey guys, today we're going to talk on frozen ulcer, also known as adhesive capsulitis. It's a synovial inflammation with subsequent reactive capsular fibrosis that results in progressive pain and stiffness of soldier. The initial triggering agent is not known, followed by the release of cytokines, metalloproteinase, and growth factor beta 1 has been implicated in the early process. Followed by there is a neoangiogenesis and neoinnervation with increased nerve growth factor receptor and a new nerve fiber formation in the shoulder capsule. This explains the severe pain in this condition. Histologically, there is an active fibroblastic and myofibroblastic proliferation in the rotator interval, anterior capsule, and a coracohumeral ligament. Risk factor for the frozen soldier are overall incidence in the population is 2%. It's 5 times more common in diabetes mellitus, more common in female, and more common in the age group of 40 to 70. Hyperlipidemia, prolonged immobilization, hyperthyroidism, strokes, and MI, and following trauma. Lundborg have classified the frozen soldier into the primary frozen soldier and secondary frozen soldier. Primary frozen soldier, whenever there is no initiating event and no abnormality on examination other than loss of range of movement, and there is a normal plain radiograph. And secondary frozen soldier occurs when it is followed by a trauma. Clinical feature in frozen soldier is pain in the shoulder, which is gradually increasing in severity and often prevents sleeping in the affected side. Stiffness. Initially, internal rotation is lost, followed by loss of flexion and then external rotation. Clinical feature usually progress in the three phase. The phase 1, the early phase, is the phase of pain. Pain is a gradual onset diffuse shoulder pain, progress over weeks to months, usually worse at night and exacerbated by lying on the affected side. So patient use the arm less, and this leads to stiffness, which is a phase 2. And phase 2 stiffness lasts for 4 to 12 months usually and associated with a dull ache all the time, and that aggravates at night, and there is a sharp pain at the time of range of movement of the soldier. Third phase is the phase of thawing that lasts for weeks to months. As the motion increases, the pain diminishes and a gradual return of motion and loss of pain, although there is some degree of stiffness persists. On examination, soldier look absolutely fine, except there might be some degree of wasting due to loss of the use of the arm and loss of active as well as passive movement on examination. Clinically, there is no absolute universal accepted criteria for the diagnosing frozen soldier, but whenever there is a loss of internal rotation up to sacrum only and 50% loss of external rotation and less than 90 degree of abduction, it is often called a frozen soldier, and X-ray is within normal limit. MRI show contracted inferior capsule and increased blood flow to synovium. Arthrogram show a reduced joint volume and irregular margin. This image shows the arthrogram. And treatment. Before knowing the treatment, a good prognostic factor are when a person is non-diabetic, seeking early health care, and the involvement of dominant hand. Treatment option. Non-operative treatment option include a supervised physical therapy for movement of the shoulder, but abduction is prevented initially to prevent the impingement until the joint movement becomes supple. NSAID is used for early pain management. Oral steroid as well as intraarticular steroid. Intraarticular steroid provide a rapid pain relief, better function and higher patient satisfaction than other non-operative modalities, and it is proven to be benefit in the phase 1 as well as early phase 2. Hyaluronate intraarticular injection is an effective ACE steroid along with less side effect. And other method can be distension, angiography, closed manipulation, open surgical release, and arthroscopic capsular release. Other method can be TENS and ultrasound may be helpful combined with active and passive range of movement and extracorporeal shockwave therapy. Closed manipulation in frozen soldier is done under general anesthesia and interscalene block for the post-operative analgesia. And the soldier is manipulated with short lever arm and fixed scapula. And the safe sequence for manipulation is FEAR, very better mnemonics that explains flexion, then extension, then abduction and adduction, followed by external internal rotation. Audible and palpable release of adhesion is good prognostic sign. Post-reduction radiograph is required to check whether there is periarticular fracture dislocation following the manipulation. And post-operative care is very important following the manipulation of soldier. Rehabilitation post manipulation is crucial as a physical therapy is initiated following day and lasts at least for 2 to 4 weeks. In some, abduction arthrosis at night is used to prevent the axial pouch adhesion from returning in early phase. And complication of manipulation are proximal humeral fracture and sometimes dislocation. So this is avoided in osteopenia and recently healed fracture and done only when the conservative management fails. And hope it was helpful. Thank you.